Hi, this will be your discussion on increased intracranial pressure. So class, when I talk about increased intracranial pressure, this may be a manifestation of a certain disease. This may also be a consequence of a certain disease process. This will be applicable on several neurologic dysfunction that we will be talking about. So, when I say intracranial pressure, your intracranial pressure is the pressure within the cranial cavity. So it is usually measured as the pressure within the lateral ventricles. So recall that we have your ventricles, okay, which acts as the passageway and then where your CSF would be flowing. So usually when I talk about the intracranial pressure, it is measured in the lateral ventricles. Okay, so recall you have your lateral, you have your third ventricle, you have your fourth ventricle. So it's usually the right lateral ventricle, to be more specific. Then, for us to understand intracranial pressure, we need to understand the Monro-Kelly hypothesis, also sometimes referred to as your Monro-Kelly doctrine. So according to the Monro-Kelly doctrine, the sum of your volumes of the brain, CSF, and intracranial blood is constant. Okay? An increase in one should cause a decrease in one or both of the remaining two. In other words, class, if there will be swelling of the brain, there should be a decrease in the amount of CSF and blood to ensure that the intracranial pressure will be the same or constant. Because these three are the non-compressible elements. You have your brain, composed 80% of your intracranial pressure, CSF 10%, then blood 10%. Whenever there is a problem with one, an enlargement with one, the other two is expected to compensate. We also have the term compliance. Compliance here refers to the relationship between the volume of the intracranial components and the intracranial pressure. When the capacity to compensate for pressure in cranium is exceeded, we are expecting increased intracranial pressure. Okay, what do we mean by this? Your brain tissues and brain contents or your cranial contents has the tendency to become compliant. In other words, okay, the contents would adjust depending on the intracranial pressure. But your compliance would also have a limit. Once the limit for this compliance is reached, or once the capacity to compensate for the pressure is exceeded, increased intracranial pressure, or what we refer to as hypertension, may develop. Your intracranial hypertension is considered as a sustained state of increased ICP, and this is potentially considered life-threatening. Okay, this is considered to be life-threatening. Okay, again, this is the failure of your compliance, which is, again, ability of the intracranial compartment to accommodate an increase in volume without a large increase in intracranial pressure. Because your intracranial contents are trying to be compliant. Although there is an increase in either volume and pressure, there will not be much increase on the other parameter as long as your brain tissues or your brain could accommodate. Okay, that's your compliance. Now, so what are the causes of your sustained increase in ICP? One is your cerebral edema, fluid accumulation in your brain. Head trauma, which may result to compression of the brain contents or the cranial contents. Your tumors, which would compress your brain tissues. Then you have your abscess, which are pus deposits. Stroke, we have your hemorrhagic stroke in particular, which would cause swelling of the brain also. Okay, the same on your ischemic stroke. Inflammatory processes, especially if there is infection. Okay, once there is autoimmune diseases. And then your hemorrhage. Now, let's try to understand the pathophysiology and manifestations of your increased intracranial pressure. This may not be true for all the disorders, but this is one explanation why there is an increase of your intracranial pressure. One, it can be caused by interruption of your cerebral blood flow. Because of that interruption of cerebral blood flow, brain ischemia would occur. In other words, there will be decrease in oxygen in the brain tissues. That would result to disruption in cerebral metabolism. Because of the disruption in cerebral metabolism, vasodilation would occur. Now, vasodilation there seems to be a compensatory mechanism for the blood flow towards the brain to improve. Because of vasodilation, there could be brain swelling. Once the brain is already swelling, there could be increase in the ICP or your intracranial pressure. If this increase in ICP would not be addressed, this would further the ischemia and would result to cell death. Let's talk about your CPP. Your CPP class is your cerebral perfusion pressure. That is the difference between your mean arterial pressure and your intracranial pressure. So what do we mean by that? If you would look at your mean arterial pressure, recall that your mean arterial pressure is computed by 2 diastolic plus systolic divided by 3. Okay, so basically it is from your blood pressure. Now, your cerebral perfusion pressure, or basically the amount of blood that can be accommodated or that can go inside your brain, is equal to your blood pressure minus your intracranial pressure. In other words, class, okay, your intracranial pressure would be able to resist the blood pressure which is pumped from our heart. In other words, again, once your intracranial pressure is increased, the blood pumped by the heart will have hard time to reach your brain. Okay? Once your intracranial pressure is increased, your cerebral perfusion pressure will be decreased. Okay? Because your intracranial pressure seems to be a pressure against the amount of blood that would be able to come inside your brain. Now, we have the term autoregulation. Your autoregulation is the ability of your brain to maintain relatively constant blood flow despite the changes in perfusion pressure provided. Okay, provided the CPP is 60 to 160 mmHg. Now, beyond that, your autoregulation mechanisms would fail. Okay, so your autoregulation mechanisms would fail. Now, there are two forms for your autoregulation. The two forms of which is your pressure autoregulation and chemical autoregulation. Now, you have your pressure autoregulation. Class, your pressure autoregulation is taken care of by your arterioles changing diameters to maintain cerebral blood flow whenever ICP increases. So whenever the ICP would increase, it is the arterioles that changes in size. Okay? Now, for us to understand pressure autoregulation, you need to remember that the stretch receptors, which can be found on the small blood vessels, would cause smooth muscle contractions. And these small muscle contractions, class, would lead to vasoconstriction. Again, stretch receptors are found in the smooth muscles, would contract, and then would cause vasoconstriction. So, what happens? When there is a decrease of arterial pressure, class, there is a decrease on the stimulation of receptors. Okay, again, once there is a decrease of your arterial pressure, okay, we don't want that because there will be minimal blood going towards the brain. And because of that, there will be a decrease of stimulation of receptors. And because of this decrease of stimulation of receptors, there will be relaxation and vasodilation of your blood vessels. The purpose of your vasodilation, or the intent of your vasodilation, supposedly is to increase your blood pressure. Okay, or to increase, the oxygenation going towards your brain tissues. Now, in chemical autoregulation, okay, class, your chemical or metabolic autoregulation is triggered by the following stimuli. It is triggered by your build-up of metabolic byproducts of cell metabolism. Examples of which are your lactic acid, you have your pyruvic acid, you have your carbonic acid, and you also have your carbon dioxide. Now, your carbon dioxide and hydrogen ions, class, are considered to be cerebral vasodilators. Earlier, I said that vasodilation is an intended reaction to increase oxygenation to the brain tissues. Okay, cerebral vasodilation would improve oxygenation in the brain tissues. But now, class, okay, let us remember again that once there will be an excess of vasodilators, that could also lead to an increase in your intracranial pressure. Okay, that's why when I'm talking about neuro, we need balance. Too high and too low will be bad for the body. Okay, again, once your carbon dioxide and hydrogen ions are increased in the bloodstream, it would trigger vasodilation. And the effect will be to increase your ICP. Okay? In relation to that, okay, or to compensate for that, there may be a decrease in your carbon dioxide levels. Okay? If your body would notice that, oops, there are already a lot of carbon dioxide, your body would try to excrete this carbon dioxide, usually through hyperventilation. Now, what could possibly happen if your patient would have overly decreased carbon dioxide? Once the PaCO2 will be decreased, class, another effect will be cerebral vasoconstriction. Will that be good for the body? No, again, it would decrease your cerebral blood flow. Okay, it would decrease your cerebral blood flow. Okay, so look at that class. An increase in carbon dioxide would lead to vasodilation, increasing ICP. But if your carbon dioxide would be decreased, it will result to vasoconstriction, and then in turn, it will decrease your cerebral blood flow. So again, we need balance. And then, if there is arterial oxygen tension, it is also expected that there will be vasoconstriction. Now, if you would look at how your autoregulation would affect, okay, class, you can notice here that once there is loss of autoregulation, there will be reduced cerebrovascular tone of blood vessels. Recall earlier that your autoregulation will be able to control the blood vessels in order for the blood vessels to be provided with adequate oxygen going towards the brain. But once this compensatory mechanism or autoregulatory mechanism is already failing, class, it would result to reduced cerebrovascular tone of the blood vessels. Now, the cerebral blood flow will become dependent on the changes on the blood pressure. Okay? Because the brain will not be able to auto-regulate anymore. If the heart will not be pumping a lot of blood, the brain will not be receiving a lot of blood, and he will not be able to do anything about it. Okay? Because the cerebral blood flow becomes dependent on the changes on the blood pressure already. Again, because of the failure of your auto-regulatory mechanism. If your auto-regulatory mechanism are supposed to be in place, class, okay, you would not expect, that there will be an increase in ICP. Okay, now, due to the reduced blood flow, that would lead to cerebral blood flow being dependent again to the changes of blood pressure. That would result to an increase in your ICP. As mentioned earlier, okay, the higher the ICP seems to result to a lower CPP. Okay, higher ICP would lead to lower CPP, okay, or cerebral perfusion. Now, that would result again to ischemia and hypoxia. There will be changes in the cortical function, which would be the first manifestation of your increased intracranial pressure. Oftentimes, it's level 2 as, okay, irritability. Oftentimes, we can see this in literature as altered level of consciousness. Okay, that is class the first sign for a change in your intracranial pressure. Now, in the early stages of your increase in the intracranial pressure, okay, this is characterized usually by the stimulation of your vasomotor centers. The stimulation of your vasomotor centers, in turn, would increase the ICP. That would lead to an overwhelmed autoregulatory system or compensatory mechanism. Because of this overwhelmed autoregulation, class, okay, there will be an overwhelmed CPP and then a decrease in your cerebral blood flow. With the decrease in your cerebral blood flow, you'll have what you call your Cushing's response. Your Cushing's response, class, is actually a hypothalamic response to the brain ischemia wherein the sympathetic nervous system is activated. Okay, this is a hypothalamic response to your ischemia wherein your sympa nervous system would be activated. This activation, class, of your sympa nervous system would cause peripheral vascular resistance with subsequent increase in blood pressure. Okay, resulting to an increase on your systolic blood pressure with widened pulse pressure and then bradycardia. Now, class, notice that what is increasing is only your systolic blood pressure. Okay, recall that your pulse pressure is the difference between your systolic blood pressure and your diastolic blood pressure. Whenever, class, okay, whenever there is an increase in your systolic blood pressure, but the diastolic blood pressure remains to be the same, okay, you would expect that there will be widening of your pulse pressure. Example of your pulse pressure. If the BP of my patient is 190 over 80, okay, 190 again over 80, you would expect the pulse pressure to be 190 minus, okay, 190 minus 80. So in that case, that would be resulting to 110. Okay, that's how you measure your pulse pressure. Recall that the normal pulse pressure would be only at 30 to 40. Okay, so class, this is classic in a patient with, okay, and a patient with stroke, okay, or a patient with increased intracranial pressure. As a consequence, there will be continuous autoregulation ineffectiveness and resulting decompensation. So because of the decompensation, class, there will be ischemia and infarction. Notice again that your ischemia, or recall again that your ischemia is decrease in oxygen and your infarction is leading already towards necrosis. Okay, now, the consequence of this would result to what we refer to as your Cushing's triad. Your Cushing's triad class is characterized by hypertension, okay, specifically, again, systolic hypertension. There will be bradycardia, and there will be irregular respirations. Okay, often class this was be described in references as bradypnea, okay, bradypnea or irregular respirations. The irregular respirations are usually described as your Cheyne-Stokes breathing, okay, Cheyne-Stokes breathing. Now, if this will continue, brain herniation or occlusion of the blood flow would occur. Once class brain herniation and occlusion of the blood flow, either of these would occur, there will be a decrease in your cerebral blood flow. Okay, or worse, there will be cessation of your blood flow, resulting or further aggravating class infarction, resulting towards the death of your tissues. Now, what are the factors accounting for loss of autoregulation? Okay, because I mentioned earlier that there is an autoregulatory mechanism that would be able to regulate the pressure inside our brain despite the increase in volume. Okay, that's how your compliance would work. Okay, through your autoregulatory system. So what are the possibilities or what are the possible reasons that would account for the loss of autoregulation? An intracranial pressure class of beyond 40 to 50 could impair your autoregulatory mechanism. Your intracranial pressure normally is 5 to 15 millimeter mercury. Beyond that, it's considered already to be increased intracranial pressure. Your patient would usually start to have manifestations when ICP is at 20 to 30 mmHg. Whereas class, if we're talking about temporal lobe problems, even at as early as 20 or less, your patient may already have increased ICP. But if it will go beyond 40 to 50, especially if it's an acute hemorrhage, okay, a multiple vehicular accident or a motor vehicular accident for that matter, class, okay, and too much high ICP would result to failure of your autoregulatory mechanism. Then, local or diffuse tissue injury, ischemia, or inflammation. When I say local, it is confined in a certain area of the brain. When I say diffuse, it is spread in other areas of the brain. Okay, so it could be an injury, it could be ischemia, which is decrease in oxygen, and even inflammation itself. This could result, class, okay, to your defect on autoregulation. Your mean arterial pressure of greater than 60 to 130 may also result to failure of your autoregulation. Either the increase of your carbon dioxide or decrease of your oxygen, okay, could possibly result to vasodilation. Recall that your vasodilation class would stimulate the blood flow going towards your brain. And this stimulation of blood flow going towards your brain would increase the amount of blood inside your brain and hence increasing your ICP. It would increase your intracranial pressure. Another risk factor class that I would like to re-emphasize is prolonged hypotension. Okay, I would like to correct the previous entry, so this is prolonged hypotension. So once there is a decrease of the MAP from the normal, which is working supposedly between 60 to 100, and that is for prolonged periods of time, you're expecting that the autoregulatory mechanisms of the brain would be failing. Okay, supposedly the autoregulation will be able to normalize the cerebral perfusion. However, if it will be prolonged, and then if we would not be giving medications to augment the blood pressure of the patient, okay, it would also result to the failure of autoregulation. Okay, there are literatures which would say that prolonged hypertension or uncontrolled hypertension would also lead to autoregulation failure. Added to that, the drugs that would cause vasodilation. In particular, you have your halothane, you have your nitrous oxide, you also have your histamine, your ketamine, and your nitroprusside. Okay, this can all lead to increased ICP and again, the failure of your autoregulatory mechanism. Okay, remember, halothane class is used in anesthesia. Nitrous oxide is used in anesthesia. Your histamines class could also be an augment for the sedative, so as your ketamines. Okay, your nitroprusside are used as cardiac medications. So class, once these vasodilation effects of this medication would be exaggerated, it could also result to an increase in your intracranial pressure. Now, what are the clinical manifestations of your increase in intracranial pressure? Class, the earliest sign of your increased intracranial pressure is your decrease in the level of consciousness. Okay? Other references would say irritability. But irritability class is usually irritability is usually related to the decrease of oxygen. Okay? Whereas the decrease of your level of consciousness will be related to your increase in intracranial pressure. Okay, but either of these choices could be signs and symptoms. Now, if I talk about decreased level of consciousness, we're referring here to lethargy, obtunded, stupor, and coma. We're referring here to your patient who is not oriented. Okay, we're referring here to your patient who is not easily arousable or could not be easily awakened. So here we are making use again of your GCS scoring and your neurologic assessment. Now, other signs and symptoms would result to pupillary dysfunction on the ipsilateral side. Again, when I say ipsilateral class, okay, if it is the right side of the brain of the patient that is damaged, it is also the right side of the eye that would have the pupillary dysfunction. Okay, then we have your oculomotor dysfunction. When I say oculomotor dysfunction, we are not only talking about cranial nerve number 3, but we're adding 4 and 6 to that. Okay, once there is dysfunction of your oculomotor nerve, we perceive that your eyes will not be able to move from side to side. Your eyes will not be able to see the 6 cardinals or follow the 6 cardinals direction of gaze. Okay? So oculomotor dysfunction. Then, of course, your vision abnormalities. So your vision abnormalities class is congruent already to the damage on your occipital lobe. Now, you might be wondering if there is a certain increase in ICP that would be focused on the occipital lobe. Come to think of it, class, once the intracranial pressure would be increased, the damage tends to be systemic, or the damage to the brain tends to be global, meaning several parts of the brain will be affected at the same time. Okay, so it may start in the occipital lobe, but rest assured that the other parts of the brain will be affected as compression would ensue. Now, other clinical manifestations, you have your papilledema. Class, your papilledema is your fluid deposit surrounding your eyes. So, class, your papilledema is also related to the compression of the venous system, okay, because of the tissues or the enlargement of the tissues inside the cranium. Motor impairment. Recall that one of the functions of your cerebrum, okay, will be to ensure that there will be motor movement. Okay, efferent nerve fibers would arise from the cerebrum for it to give us the signal on what to do next. Other than that, class, your cerebellum may also be affected because of the increased ICP, hence affecting also balance and coordination. Headache. Class, your headache. One of the pathophysiology of your headache is increase in the intracranial pressure. Okay? But please don't think that if you have a headache, you already have an increased intracranial pressure. That will not be true in all cases. But your headache, okay, one of the explanation, class, of your headache is vasodilation. Your patient would also manifest with projectile vomiting without nausea. So this forceful vomitus is brought about by the increased pressure also on your intracranial, okay, on your inside your cranium. Then you have your Cushing's response, and then you also have your Cushing's triad. So your Cushing's response is brought about by the failure on the autoregulatory system. Okay, then you have your temperature. So temperature, because of the impairment of the functioning of your hypothalamus, which can be found in your diencephalon. Okay, your patient may manifest with high fever. Now, this is the confusion when it comes to a patient with altered LOC because your fever becomes an unreliable sign already for infection. The fever may indicate an impairment in the functioning of hypothalamus. Also, on the other hand, the fever may indicate a growing infection inside the patient's body. That's why to confirm for the presence of infection, you need to do further testing such as your WBC, your culture and sensitivity, and of course, observation of the signs and symptoms of the patient. For example, sepsis in particular could result to the deterioration of the level of consciousness of the patient. So if that is added to an altered level of consciousness problem related to stroke, for example, there will be a confusion whether the patient is experiencing septic shock or if the patient is having complications of your stroke. So you need to pay attention to the clinical laboratories of your patient in order to diagnose this early. Another cause for the increase in your intracranial pressure is your cerebral edema. So your cerebral edema, I'll be discussing this in the succeeding lecture. Thank you very much for your attention.